Welcome, everyone. I am really thrilled to see you all here this evening for what I know is going to be just a fascinating and really important conversation. I'm Dr. Shoshana Ungerleiter. I'm a practicing internist at Crossover Health in San Francisco. I'm the host of the TED Health podcast and the founder of Endwell, a nonprofit media platform and annual convening dedicated to making the end of life a part of life. And so I'm really excited to start by introducing our experts. Rachel Yehuda, Dr. Rachel Yehuda on the end is an endowed professor of psychiatry and neuroscience of trauma. She's the director of mental health at the James Peters Veterans Affairs Medical Center. She's a recognized leader in the field of traumatic stress studies, having authored more than 500 academic papers in the field of PTSD and intergenerational trauma. Her research on cortisol and epigenetic mechanisms has really, truly revolutionized our understanding of neurobiology and the treatment of PTSD. In 2019, she was elected to the National Academy of Medicine for her seminal contributions. In 2020, Dr. Yehuda established and now directs the Center for Psychedelic Psychotherapy and Trauma Research. And next we have Dr. Jishan Chowdhury. Jishan is the
Not gone after Rachel.
I know, right? She should have been last.
Tough act to follow, yeah.
Jishan is co-founder and CEO of Journey Collab, a biopharmaceutical company really unlocking the science of psychedelics to build a new model of addiction care. Jishan is an MD, PhD, and did his graduate studies in informatics at Oxford as a Rhodes Scholar, and he completed the CIIS training course in psychedelics. He's a very seasoned entrepreneur, which we're going to hear all about, starting multiple successful companies and is the recipient of multiple national level research awards. Next up, we have Andrew Penn. Andrew is a psychiatric nurse practitioner and associate clinical professor of community health systems in the School of Nursing at the University of California, San Francisco. He works on psychedelic studies of psilocybin and MDMA in the translational psychedelics research and practices at the San Francisco Veterans Administration. Andrew is truly a leading voice in nursing, is co-founder of the organization of psychedelic and entheogenic nurses, really advocating for the perspectives of nurses in psychedelic therapy. So tonight, with that, we're having a conversation with these incredible experts about the potential for psychedelic medicines to transform mental health care. And I want to quickly set the stage for this conversation to get everybody on the same page about what we're talking about. For those of you in the room who are experts on this is going to be a little basic, but bear with me. I promise we'll get into the juicy stuff. We're all aware of the mental health crisis in America. This is a huge burden for people, for families, for clinicians, and our healthcare system. COVID has only made this worse. In any given year, an estimated 18.1%, which is 43.6 million US adults over 18 suffer from mental illness. We don't have enough psychiatrists and therapists to meet the demand. And the treatments we do have, to say the least, don't work as well as we would like them to. So how might psychedelic-assisted therapy be helpful? Well, that's what we're here to talk about. And let's start with just a tiny bit of context. In the 50s and 60s, if you didn't live through that period of time, psychedelic research really flourished all over the world and showed great promise for the fields of psychiatry, of psychology, and neuroscience. But psychedelics leaked out of the research setting and began to be used by the counterculture and by the anti-Vietnam War movement. And there was a backlash. So in 1970, the US government criminalized all uses of psychedelics, and they started shutting down all psychedelic research. And this ban really spread all over the world and lasted for decades. And it landed us where we are today. And yes, psychedelics, aside from ketamine, are still illegal in this country outside of a clinical trial. So with that said, let's dive in here. Andrew.
And no, we don't have any samples.
No, we're not giving it out tonight.
Sorry.
Andrew, right now, psychedelic-assisted therapy is being studied in clinical settings for everything from PTSD to depression, substance use disorder, OCD, end-of-life distress, prolonged grief, and many others. So for people who aren't familiar, these clinical settings create a very different scenario than a recreational use of psychedelics. Can you walk us through what it's like to be a trial participant, for example, and specifically, how does the assisted therapy component come into this?
Yeah, absolutely. Well, I'm glad you talked about that, about this being a therapy-focused process, because really in the press, it's the drugs that get a lot of the attention. And what these compounds are doing is they're helping to catalyze psychotherapy. And so psychedelics are very contextual drugs. So by that I mean the experience, where you're having the experience, with whom you're having the experience, is a significant determinant of what's going to happen. And if it was just the drug alone, then Burning Man would be curative for a large number of people, or Woodstock, depending on your vintage. But we know that the drug alone doesn't do the work. So in our lab, and our lab is similar to many others that are doing this work, we begin with several sessions of non-drug psychotherapy. And we work with 2 psychotherapists. Historically, it was a male-female dyad, but we're now eliminating that for greater flexibility and also gender inclusivity. And we'll have 2-3 2-hour sessions with the subject, getting to know them getting to know us. We're starting to create a container, a therapeutic container where this can happen safely. We want to know what issues they're coming into the session with, what their history is with, be it depression in the studies that we're doing with psilocybin, or PTSD in the studies that we're doing with MDMA, what their concerns are, what their fears are about the experience. We walk them through what the day is going to look like. We might rehearse reassuring touch, if that's something that the subject is okay with. And then we'll have them actually practice lying down on our couch. And we have eye shades, we have headphones. And then, so we do that a couple of times, 2 or 3 times before we actually have the dosing session. The dosing session lasts all day. They come in the morning. They've obviously already done their physical exams, gotten that all of the way so that we know that we can do this safely from a physiologic standpoint. The drug is ingested usually 9 o'clock in the morning, and then we're there all day. And during the therapy session, there may not be a lot of talking going on. So it may not look like, when you think of conventional psychotherapy, more of a dialogue happening. We often encourage people to direct their attention inward. That's where the eye shades and the music are useful. And then afterwards, starting the next day, so the drug will wear off after 5-7 hours, depending on the drug. And then we begin what we call integration psychotherapy, where we start to unpack the experience of the day before. I try and make sense out of the experience, try and identify themes, identify opportunities for change, because what this may represent is a period of possible neuroplasticity, openness to change, and we look for opportunities to make actual actionable change in that person's life towards their intentions of healing.
Thank you. And Rachel, Andrew touched on this a little bit, but we hear the concept of intentionality being used when we talk about the therapeutic experience with psychedelics and the framework of set and setting. Why is this important?
Oh, thank you. And it's a pleasure to be here. And Andrew did start us off with answering that question. But understanding intentionality and set and setting with psychedelics is probably the most important thing you're going to hear tonight. And I'll just elaborate on your example. Let's say you have a drug like MDMA, ecstasy. So if you take it in a recreational context, what does ecstasy or MDMA do? It reduces your fear response. It promotes pro-social behavior. It makes you less judgmental. It makes you more likely to engage with people or trust them more. So if you're in a recreational context, then you might have a really good time meeting people. You might dance or feel less inhibited than usual. You might trust people, maybe take them home and continue the evening with them, if you will. But in a therapeutic...
I don't think there's any documented cases of that ever.
Especially not a Burning Man. But if you want to use this drug in a recreational in a therapeutic context, then those same properties start to work for you in different ways. You harness them. So the reduction in fear becomes more of a willingness to engage in exploring traumatic memories that are scary. The pro-social behavior becomes a connection with the therapist, the building of interpersonal trust. So you basically take the same properties of the compound, but you harness them. And you harness them in the presence of trained therapists. You can take that same experience and really have a very deep psychotherapeutic process. That's the intention part. The setting part is that you're not at a rave, and you're not at a party, and you're not at a festival. You're in a room that is safe with people who are going to keep you safe. And you are able, in that safe room, to be able to go very, very deeply into material that usually is not accessible because of the anxiety of what the material is, that you'll run out of time, that you won't get to say it, that you don't trust the people to listen to it. But this promotes a very different kind of a process.
Thank you so much for that. Jishan, can you set some more historical context for us? Psychedelics have been around a real long time. There is a very long history of human use of these substances. Can we talk about that a little bit?
Yeah, I mean, I think the best, well, first of all, thank you for having me. It's great to see so many people from the Aspen community join us here. I think the best way to describe is that this moment in time that we are living of prohibition is really an aberration of all human history. Humans have had relationship with psychoactive plants like psychedelics for thousands of years. This is not just something that we take from the oral tradition, but there's hard evidence around that. My company works with mescaline, which comes from the peyote cactus or the wachuma cactus. The earliest evidence that we have of fossilized peyote buttons in specialized burial sites goes back to 5,700 BC. We have similar evidence for ayahuasca, for mushroom use. And so we, as humans, have multiple relationships with plants. We use them for food, obviously. We use them for textiles and our clothing, for structures, our lumber. And we know that we use them for physical medicines. Aspirin, or up all the way to new medicine like Taxol, comes from plants. So the idea that we would not use plants for mental health and for psychiatric healing is also an aberration. And so we have a long history and almost a universal history of using these type of psychoactive compounds. I think other than the Inuit, where there's just simply not much that grows there, almost every society that we have encountered has some tradition of using psychoactive substances, particularly for healing. And to what my colleagues here have said, when we look at those communities, it's always been done in a ritualistic setting. It's always been done with intention. And I think there's a lot to learn, not only from the fact that where we are in this forced period of abstinence, and we know how forced periods of abstinence usually work out in multiple dimensions, that we have an opportunity to have a relationship again with these substances, with these plants and with these psychoactive compounds, and I'm really excited about where we're going with that.
Rachel, I want to come back to you and talk about what you're doing in your lab. It was there that you were doing some of the very first studies to look at the biological underpinnings of PTSD, and have studied intergenerational epigenetic transmission of trauma in military veterans, in Holocaust survivors. And PTSD, as many people probably know, remains very, very difficult to treat. Mm-hmm. So, Rachel, you started out as a skeptic and have really become an advocate, of course, for psychedelic-assisted psychotherapy research. And you now, of course, established and now direct the Center for Psychedelic Psychotherapy and Trauma Research. So tell us about that journey.
Oh, okay. Thank you for asking. Well, I would have been skeptical of any claim that anyone had that a treatment in such a very short time can take away somebody's PTSD. Scientists are naturally skeptical people, and PTSD is a very difficult condition to treat. And I'm not an advocate for using psychedelics, but I am an advocate for doing the research on it. And what started to flip my process. Of course, when the initial study came out, I just thought, what is this? A very large effect size, but a very small study. And I thought, I don't really understand this. But as more studies came out that kept showing pretty large effect sizes, I started to pay more attention. But when the FDA declared MDMA-assisted psychotherapy a breakthrough treatment, that really changed things for me. When the FDA declares something a breakthrough treatment, what they're saying is this is better than anything that we've got going on right now. And so for somebody that really cares about PTSD and wants to study it so that for the purpose of really learning how to treat it, it became an issue of how could you not study it. So I knew that it was going to be difficult to get more conservative mainstream academic or community settings to kind of want to look at this, especially in this early stage before it is made legal or approved as a treatment. But I thought these are the populations that really need to be studied the most. And so it really became a moral imperative of sorts. You can't look at a treatment that is really doing twice as well as the standard of care. I should say twice as well as the standard of care, but still leaving some people with symptoms. So that's very important to not walk away thinking that this is a treatment for everybody. But that made it even more important, like who responds, who doesn't. And we had been studying biological predictors and correlates of psychotherapy and other treatments. So we were in a good position to kind of take this on, and that's why we established the center at Mount Sinai.
Thank you. Andrew, I want to talk about an area that's really near and dear to my heart and my work at Endwell. Mm-hmm. And it turns out we don't have the tools to be able to adequately care for people who have existential fear, dread, and distress when diagnosed with a terminal illness. Mm-hmm. And the medicines that we do have for anxiety and pain tend to blunt the senses and not allow us to live fully until we die. So tell us why psychedelics might be helpful for patients and certainly their families who are facing a life-limiting illness, and what has the research shown to date on that?
Yeah, so this was one of the very important earlier studies, and the field is moving so fast that it feels kind of ridiculous to say something that was published in 2016 was an earlier study, but it is. So there was a pair of studies that were done, one at NYU and one at Hopkins, that looked at people with life-threatening illness who had anxiety around that diagnosis, whether largely cancer. And they were treated with this course of psilocybin assisted therapy intervention. And outcomes were significant. And they measured a number of things in that, but depression and anxiety around the illness and depression and anxiety in general were measured. And the vast majority of people had what's known as a response, which is that they got somewhat better, but a significant number of people remitted, even at the end of 6 months of the study period. And some of the people that continued that didn't pass from their illness, that were followed, the effect lasted as long as 4.5 years. And so there was something about this shift that was really important, and it really underscores the need that you pointed out, which is that we don't die well in this country. We've developed incredible medicine to help us live for a very long time, but when it comes to dying, despite the really valiant efforts of people like Cicely Saunders, who was a British nurse who started the modern hospice movement, and palliative medicine, we do a really good job of managing physical symptoms. We can help people be comfortable as they're approaching the end of their life. But when it comes to their soul, their spiritual needs, we call the chaplain, usually. If you're in a hospital, you call the chaplain. And no knock on chaplains. Some of my best friends are chaplains. But we really, and it's challenging because we live in an increasingly secular country too. So what do we give those people? And so whether you're religious or secular, it doesn't matter. The soul needs things like meaning and connection and love and purpose. And what these treatments may allow people to do is to review their life. Goethe said, if you haven't died before you die, then when you die, you really die, or something like that. He was really concise with his words. But this idea that we actually get a chance to practice dying in this kind of treatment, and that maybe it becomes not so frightening, because there is this phenomenon that happens, especially with psilocybin and serotonergic psychedelics, where sometimes people call it ego death. But this idea of shifting from that, my worries and my story and my concerns are kind of the center of my universe, and they preoccupy most of my time, to stepping back to what, if you heard the speaker last night talking about a state of awe, in a state of something much bigger than ourselves, where, we're still part of it, and we still have an importance, and we don't disappear, but that there's so much more. And that if we can connect to that, especially as we approach, hopefully we don't have to wait until the end of our lives to connect to that. But if that's the case, well, then so be it. But that may be what's happening there.
Powerful. Jishan, I want to talk a little bit about the pathway. So how does a compound like MDMA or peyote, for example, help to, I sort of think about it like clearing a path to healing, or to allow a person's innate healing maybe to be activated? How do you think about this?
That's a very tough question.
Okay.
I will say that we don't know how a lot of things work in medicine. So does anyone use Tylenol here before? If you ask a scientist how Tylenol works, we have some ideas, but what we know is that it's an empirical story rather than a scientific story. We know a certain dose reduces fever, a certain dose reduces inflammation, and now over like 100 years of scientific research and an incredible last few decades of clinical trial research, we know that certain doses of serotonergic, what we call these classical psychedelics, can produce these outcomes. We have some idea of, we have some theories around it. We know at the receptor level that they introduce what we call neuroplasticity. So like you'll actually see whether the synapses in the brain, like making new connections. With fMRI imaging, we know that different parts of the brain talk that weren't talking before. And from like a psychological level, from the insights that people are able to face with, from what Rachel was saying, having your fear response reduced to be able to process trauma. So these things are happening in parallel and together. What's really interesting is this idea that you mentioned of this inner healer that the brain has. And I'd use the analogy that if you cut yourself, depending on the severity of the wound, you may need to wash it out. You may need to approximate the wound with sutures. We may put a bandage on, but you don't need to tell your body how to heal. It will heal itself. And something seems to happen in the psychedelic state of consciousness when it's done with the right intention in a safe therapeutic setting, not necessarily at Burning Man, that this inner healer starts to function and work, and people start to work through the traumas, adverse events, the issues that are facing in their lives. And we often tell people you may not get the trip that you want, but the trip that you need. And I think that's also a reflection of this inner healer that is functioning. And I think it's the awe of the human mind and the human psyche that when given a safe space to be able to process, that it can heal itself.
I want to switch gears a little bit, and I want to start with Rachel and jump into the policy realm. Now, this is sort of a question for everybody, but we'll start at the end here. And so we know states like Oregon and maybe soon Colorado are passing legislation to make psilocybin, for example, legal. So what are the pitfalls of fast-tracking state-level legislation, such as in Oregon, and where do you see the potential for issues to arise?
Well, that's a complicated question. I was hoping to get the question about how the drug works. Yeah. So
we can come back to you on this
no,
if you want.
it's okay. I'll do it. But it's not gonna necessarily be what everybody wants to hear, because I have some real reservations about this.
Absolutely. Good.
And it's not that I don't think that it should never be legalized or anything like that. And I really take what you have said about like our whole history of the use of plant medicines, and I understand that perhaps the reasons that caused these substances to be banned were political more than anything else, and all of that is true. But I have two sets of concerns. One really involves whether we know enough about the safety of taking psychedelics in this culture, in this time, in this here and now. to be able to say, as we are saying when we bring these bills forward, that these compounds are perfectly safe. Now, that the compounds themselves are not as dangerous as many drugs that we have that are legal, such as, for example, opiates.
Even alcohol.
Even alcohol. So we don't worry so much about the physical properties of the drug or the toxicity or even the addictive nature of it. But psychedelics can increase a lot of psychological vulnerability. And so then the question becomes, who can facilitate? What happens if somebody, I know this happened to me so many times where somebody is taking a psychedelic for what they think will be recreation or exploration, and they'll uncover a memory of a trauma. Now, the facilitator who does not have a mental health background is not going to be equipped to deal with it. Maybe they can go through that 6-hour session okay and have a phone call the next morning. But this might initiate a process. So in a stressed mental health system, do these bills build in harm reduction, and do they build in mental health treatment or the influx of more mental health treatment that people will want to have if part of their exploration involves this? So it's not that I don't think that these medicines should be legalized, but I think we don't want to walk into this naively without harm reduction and without making sure that our mental health systems and the people that work in the communities where this is legal, even if they're not going to ever deal with psychedelic drugs, they're going to have to understand what has just happened to somebody with a facilitator that now ends them on your doorstep. And I just want to make sure that we have the resources for that. So that's one set of concerns. The second set of concerns is really about timing. Timing is everything, right? Is this what we should be doing now? We're on the cusp of perhaps advancing MDMA and psilocybin as treatments for PTSD and depression, because the FDA has given both of those treatments breakthrough therapy. What will the impact be? Will that facilitate that by making it easier to study these drugs because they won't be illegal? Or will it undermine it by making this more about business opportunities for having a spa for your brain or CEOs optimizing their performance? Or will it be in the places where hopefully these medicines can do the most good in community settings and at VAs, reimbursable, insurable, medical? What will the impact be on that? Now, if we've thought about that and we don't think that this will sabotage that the way maybe cannabis did sabotage that, then great. If we can put in harm reduction because we're walking in with our eyes open, great. But to walk in because these are the greatest drugs on earth and there's no problem to them, I think is a problem for me.
No, I'm so glad that you're saying that, Rachel. And if I could
Please
put a plug in for psychedelic harm reduction. Because one of the things that these compounds do, which can be leveraged in a therapeutic setting, is they decrease what we call experiential avoidance, which is that people develop all sorts of strategies to not feel their feelings, from using substances to any number of different strategies. And what psychedelics tend to do is they tend to put all that right in your face. They can. And so that's why the old adage of you don't always get the trip you want, you may get the trip that you need, but that may be very, very difficult. And so I've done psychedelic harm reduction at Burning Man. I've been going to Burning Man since 1998, so.
Hey, anyone else going to Burning Man this year?
Yes. Any other burners in the room? Yes. Rachel's been to Burning Man? Yes. I clean up well. So I've worked with a offshoot of MAPS, which is the organization that's sponsoring the MDMA work, called the Zendo Project. And the Zendo Project is a space where anybody can come to who's having a difficult time emotionally. Sometimes that may involve a psychedelic. It may just be because they've been awake for 3 nights and they just broke up with their partner. It doesn't matter. They can come and we have trained volunteers who will sit with them for as long as they want. If they want to talk, they can talk. If they just want to sit, if they just want to sleep, they can sleep. But it's a safe space so that you don't end up in law enforcement or an emergency room when you're having maybe one of the most difficult times of your life. And a colleague of mine, Josh White, has rolled out an organization called the Fireside Project, which is actually it's a telephone number. You can call it, you can text it, and they have similar trained volunteers to work with people who are having a difficult experience or have recently had a challenging experience that want to integrate it. So these are the kind of things that we're doing to try and reduce this harm. But to Rachel's point, these are powerful tools. And any powerful tool that can have this much positive impact can have a commensurate amount of harm. Now, it's not the same kind of harm we're seeing with like fentanyl, because people aren't going to, if you can't take enough LSD to stop breathing like you can with opioids, but you can have very challenging emotional experiences. So this isn't for everyone. And one of the big questions that I don't think we've done a good job as a field of identifying is, who is this not good for? That is something we need to determine just as much as figuring out who this works for.
Jishan, to you.
Yeah, I mean, I would approach this question is that we've been in this war on drugs, and we're moving to like what does the peace look like? And a war on drugs is a misnomer in that this is an uncomfortable but uncontroversial statement to say that the war on drugs is a war on people. It's been a war on brown and black people primarily, and a war on the women who have held these traditions alive for so long. And so as we move into the peace, we have lost the people who, quite literally, we've burned them at the stake, we've put them in jail, we've wiped out their cultures and their communities, that we don't have that cultural context, we do not have the literacy, we do not have the rituals that these other cultures have had. And so we're moving into the peace without these tools. But I do think there is a lot that we can learn from those traditional communities. And again, like in those communities, these have always been seen as very powerful tools. They would use the word sacrament, but I think we can say these are powerful tools. And there was always a ritual around them. There's always been a reverence and a respect to them. And how we do that in a secular setting that is accessible to all, I think that's an open question. But I think there's a lot of groundwork that we need to do. I think there are some things on the war on drugs that we can move very quickly, which is in terms of mass incarceration, expunging people's records. Those are things we can do now. But in terms of like what this is going to take for us as a society to integrate, I think we need to learn and spend the time building that infrastructure.
Yeah. So this is a question for Andrew, and I'm coming to Rachel next on this. One area where there's an urgent need, and you've touched on this a little bit, is for training guides or facilitators of therapy, right? So given the amount of demand that's out there, and as access will increase, where do you see this headed? And can you talk about the role of nursing in this work?
Yeah, sure. So there's going to be a huge bottleneck. When this gets FDA approved, we're going to have a few thousand people, maybe at most, who have actually been trained to do this work. And as I said at the beginning, this is primarily a psychotherapy process. This is not just giving somebody a pill and walking away. This is, you have to train people in how to navigate these spaces and how to help people through them. And we're going to have a real shortage of people who know how to do this. And we're going to have a tremendous amount of demand. Because honestly, that's what happens in psychiatry, right? So it happens in medicine, but it particularly happens in psychiatry. Probably because we have so much unmet need, that there's going to be so many people who are going to be lining up for this, and we're not going to have the therapists for them. And we also have to make sure, as Rachel said, that this is covered under commercial insurance. So this doesn't just remain something that is for people that have excess wealth. They can buy this. So one of the places that I'm particularly interested in this as a nurse is that a lot of the inherent ethos of nursing line up very nicely with psychedelic therapy. So nursing is about care more than it is about cure, which is largely what we do. It's about presence. It's about spending long periods of time with people. So, when I tell my therapist friends, well, a psilocybin session can be 8 hours, they say, 8 hours? I do 50-minute sections. I say, yeah, we do 12-hour shifts in the ICU. 12-hour shift with somebody who's totally delirious, that's an ICU shift for a lot of people. So the idea of being present with patients for that period of time and allowing this natural healing capacity to manifest is something which is very aligned with nurses. And nurses, it's oft repeated, are a very trusted profession. And so, and we're sort of the people. So most people know a nurse, they have sisters, nurse, or family member. And so, it's sort of very naturally aligns, and it's also a way of getting this into places that are not Aspen and that are not San Francisco and not New York. because there's people suffering in South Dakota who are going to need this too, and I'm not sure there's too many psychedelic therapists there in South Dakota. So in scaling this, we really need to think about workforce development, and there's 3.8 million nurses in the United States. And so I don't think it would take too much additional training to get nurses who want to do this kind of work on board with it.
Yeah. And Rachel, can you share about your training program for VA and community providers?
Oh, yeah, sure, thanks. So thanks to a very generous philanthropic gift from the Bob and Renee Parsons Foundation, we were able to expand a program that started pretty small into a program where we could offer therapists working at VAs and community settings the free MDMA-assisted psychotherapy training. We're doing this in partnership with MAPS, who's going to certify and credential us to be trainers and supervisors. Now, what I think is important about training isn't just to create people who can work with psychedelics. I think we want to be training all clinicians about what it means to be in an altered state, how to facilitate a process, what it might mean for them if somebody comes to their office saying that they participated or took psychedelics and they had a revelation, how they can work more with them. Right now, in traditional settings, if a patient comes and says, oh, I had the most incredible experience, I took LSD and then I took mushrooms and I really want to talk about it, they would make a consult to the substance abuse program probably, right? And you're laughing, but that's what I would have done 5 years ago. I would have said, oh, boy, this is somebody that has a substance abuse problem. So that's the kind of education that has to happen on a fundamental level. We have to start introducing courses in medical schools and graduate schools that talk about what psychedelic medicines are, because unlike other medicines in medicine and psychiatry, we've been emphasizing that they're a tool to assist in psychotherapy. Right? So the chemical properties, which we know, the receptor actions, which we know, all of the plasticity, all the things that we know about these drugs don't really quite explain the phenomenon of why taking these drugs in the presence of psychotherapy occasions a therapeutic process or an insight that then leads to symptom reduction. So I think I feel very fortunate that we're able to offer this training for free. There are a lot of places to get trained in psychedelic-assisted psychotherapy, but they're expensive. And so most people make the investment if they want to shift their practice, because then they will be in a position to also charge a lot of money for these treatments, which they should, because it's a lot of man hours. If you're in private practice, you have to recoup that. But a clinical setting, or a community setting, where people are salaried and there's a great high need, might be a place. If these therapies are found to really be a game changer in terms of reducing symptoms or getting people to a place where they don't need to keep coming every week for months or years or decades, if there could be like a more intense interaction the way it is when you go to a surgeon, right? He's going to work with you very, very intensely. And he's going to become the most important person in your life, for the prep and the surgery and the aftercare. And then you won't even remember his name next time somebody wants to ask you for a good surgeon, right? You might not even remember who he is or where you put his phone number. So that's the promise of this approach, that instead of keeping people in for really long periods of time, years and decades, that we have something that is intense, that is labor intensive, but that may actually cause a breakthrough. Now, we don't know yet if that's going to happen. That's why we're doing this research. That's the promise of it. And so we don't want to confuse the potential for this to be a new paradigm of care with the fact that it's a done deal yet. And that's why these forums are so important, because public education is so important too. You have to know this. We all have to know this. And we have to follow the process and kind of be able to separate the hype and the sexy part of the altered state and the drug from really the fact that getting over mental health problems is hard work because you have to go to places that are so difficult. And if this is something that, kind of is like a chemotherapy or a surgery or one of these really invasive things that you do for a short period of time to come out the other side, perhaps with little boosters now and then we have now transformed the landscape of mental health treatment.
Wow. I want to... Jishan, I want to go a little bit deeper into this because maybe it's obvious to you all, but this is something that is sort of just kind of dawned on me. We're talking about the potential for psychedelic-assisted therapy to be maybe curative for mental health issues, potentially. So you're shifting from maybe treating symptoms to addressing underlying mechanisms. Maybe I shouldn't go as far as to say the word cure, right?
Yeah,
but how do you think about this?
Yeah, people that deal in mental health don't use the word cure.
Yeah.
We never use it. We think about it as maybe a little remission or very long periods of good functioning, episodes of care, right? We have a language, and in our language, it belies our belief that, if you have once had mental health problems, we're on deep surveillance for you to maybe have another episode at another time. And that really, really good care is when you can go for a long period of time in between episodes. Yeah. So again, it's a hopeful thing. Now, I think that it depends on if you believe that underneath these mental health issues is a trauma, is something that you need to look at, is something painful that you haven't dealt with because it's too overwhelming to deal with. And so the promise here is that maybe if you can go there and you can shift your mind about it, you can see the world in a different way, you can get unstuck from being stuck, then maybe you have a chance to go forward. Another event can bring you maybe back, but maybe you'll have better tools to get out of this quicker. So no, I'm not using the word cure yet. Okay. I think we need to do a lot more research and much more longer-term follow-ups, but that's really where the excitement is coming from. That you see the possibility in a way that you don't see it for treatments that you have to take a pill every single day for.
Yep.
And if I could add to that, psychiatry is an interesting field because 30 years ago we had the decade of the brain. We had some tremendous advances such as your work with cortisol, and really understanding the neurobiology of the brain. But there was also this idea that perhaps we could eliminate mental illness through chemistry, and that's fallen short. If we're going to be honest with ourselves, that's fallen short. We've had tremendous advances, and it also hasn't fulfilled its promise. And so, I think sometimes we in psychiatry, we kind of have science envy. I have oncology envy personally right now, because in oncology in the last 30 years, they've made tremendous advances, right? And so in oncology, it used to be, it was categorical. You either had cancer still or it was eliminated, right? And now we define success often as arresting a tumor. We have things like checkpoint inhibitors that arrest tumors from growing. So you can be riddled with tumors for years, but you're not dying of it because the cancer's not advancing. You're living with that cancer. And I think when I expand this into mental health, I think of this idea of either you're sick or you're ill. It doesn't work in psychiatry because the maladies that we treat in psychiatry are really, in some ways, just the extremes of normal human emotional experience. I mean, where's the line between sad and depressed? We can create one in the DSM, but it's an arbitrary line. So this idea that we're going to have, the cured and the sick, I think is naive. But what I do think might happen is that we change the relationship that the person has with the illness. So that, this idea that pain and suffering are not the same thing. That suffering is about the relationship that you have to pain. So in psychiatry, the pain may be your traumatic childhood, but the suffering is the story that you have around that pain. And what I see in the work that we do is that people begin to slowly change the story that they have about their own life experiences and their own illness. And that's what alleviates the suffering. And they may still have that disease, but that's okay, because it's not impeding their life.
I think when I was in med school, you basically were looked down if you went into psychiatry. It was like the last thing to look at. People wanted to be surgeons. They wanted interventions. They wanted to be able to make a change. Like surgery is attractive because you go in, you do the surgery, it's an acute bundle of care, and you make an intervention. But we are ushering in an era of interventional psychiatry with these tools where we're not just watching, we're not throwing the same drugs at patients, like we're actually giving these interventions that are these acute bundles of care that can get patients into, well, I would say like psychiatric remission for their disease, and there may be episodic care that follows after there. But that's really exciting, and I think the next generation of like students and clinicians will want to join. Like I think there is, the workforce issue is a bottleneck, but I am hopeful that with these tools that more and more people will step into these careers and want to join them. And I'm excited for what we call this, like it's a healing economy where we're in a world where many of the jobs that we have will no longer exist. But these are jobs that you cannot outsource and you cannot automate. That they can be run by local centers, by people who look like the people they're trying to treat. And that is a very vibrant economy that we are headed towards.
I love that. Yes, Rachel.
Yeah, I love what both of you said. I really do. I just think that we want to keep in mind that some psychiatric conditions and mental health presentations are very biological.
Absolutely.
And we're going to need all the tools that we've collected in order to really figure out which thing is which. So I think where psychedelics-assisted psychotherapy can help the most is potentially when there is some shift that needs to happen in someone's thinking. I really love how you framed it around thinking differently about your condition. But we all know people whose mental health symptoms seem almost organic or, and very non-experientially based. So we're going to have to really do a lot of work to figure this out, and ultimately we'll be able to develop an algorithm. And I think a lot of the science we've developed will come in handy as we try to use these science tools to really figure out, what's what. So as long as we don't immediately throw out the old and usher in the new, that's not nuanced. We have an opportunity here to add something in that might explain why we're not helping so many of the people that are not helped by traditional methods, understanding that this also will not be helpful to certain kinds of presentations. Right. So I want to just make sure that we keep the richness of individual differences and the expertise of providers to really know the difference and be able to use their skill set to be able to match people to an approach.
I mean, there's certainly not for everyone. We know right now that if you have a history of psychosis or you have family history of psychosis, like a first-degree relative, so like a parent or a sibling, or even now like an aunt or an uncle, that psychedelics we currently can't treat with. And so we need more tools in the toolbox.
Yeah. And to be clear, in sort of a lot of the dialogue around this, there's been such effervescent exuberance around psychedelics. To the point where I'm kind of exhausted by it personally. And I understand where it had to come from, because we had to overcome the gravitational pull of prohibition. And so in doing so, we've created a lot of what I'm concerned are unrealistic expectations. And we're still going to need conventional psychiatry and psychedelic psychiatry. It's not an either or. If anything psychedelics teaches you, it's to appreciate paradox. This is not an either or world, it's a both and. And this is, and we have to keep this sort of a meta process here, that we have to keep that in mind, that this isn't going to eliminate conventional psychiatry, nor should it, because they're not for everyone, and conventional psychiatry works for some people. But for those whom it doesn't, let's have this as an option once we have the science to show that it works.
Okay. I think we want to take some audience questions. Who has questions about what they've heard? We'll spend about 10 minutes. And I just want to say, please phrase your question in the form of a question. We'll try to get through as many as we can. And we actually, unfortunately, even though we're all clinicians and scientists, we cannot answer medical questions. And we can't offer medical advice. So please keep that in mind as well.
Doctors, but not your doctor.
That's right. Okay.
Well put.
Ready.
Like that.
Hey, thanks. My name is James Corbin. I'm an ethicist. Question is that when marijuana became legal here, people don't want to admit it, but a lot of people were doing it already, and they hit the ground running. So we're seeing the same thing in psychedelics right here in Colorado and across the country. So any thoughts on that and guidance for those who are doing it? Many of you you'll meet next year when you're here for the big conference. Big ups, Andrew.
I'll start off. I mean, I think marijuana and psychedelics are very, very different things. Cannabis is it can be used as a psycholytic tool. I think there's we see an established recreational market for it, a social market for it. Psychedelics are very, very powerful tools. As again, I'll come back, like the only people who have mastered this at scale are traditional indigenous communities, and they don't use it like how we use cannabis. Psychedelics, it's always been used as a ritual in a safe setting, and I think we need to learn from that exclusively.
Next question.
Hi, thank you so much. It's so exciting to live in Aspen for the last 6 years and have this conversation at the Aspen Ideas Festival. Awesome, thank you. As a individual, not a PhD, who is a huge advocate for psychedelics, deep reverence for ritual setting, admiration and deep respect for the concerns, completely, and also believes in them so much that my friend, would love to participate in this as a career. And also, do you have any advice for somebody in that field in a community who wants it? Absolutely, but there is no guidance yet. So what can I do tomorrow or the next day? What are the initial steps into really respecting this and playing the part into bringing it into communities that could be served? And do you have any advice for that pathway?
So you mean becoming like a facilitator or a guide yourself? Yes. Who would like that?
I mean, right now, the two places where this will likely be legal will be in religious contexts and in medical contexts. So that kind of creates either a situation where either your doctor or your priest become gatekeepers. Now, places like Oregon, where this will soon be legal in a sort of overseen, facilitated setting, introduce a third way. I mean, to your question, I think learning harm reduction and learning temperance, I think, is really important. I think one of the places we got in trouble with this last time was it saying this was for everyone, for all reasons. It's not. It's really not. And if we're going to do this right this time, we have to learn where it's appropriate and when it's not, and how to say no when it's not appropriate. Because that's the nuance that we have to do better this time than we did 50 years ago.
So for folks who are non-clinical, they have no background in medicine and therapy, is there any pathway for somebody to become trained in being a facilitator or a guide?
I mean, they're doing that in Oregon. Yes, they are. They do have a pathway for non-clinician facilitators. We'll see how it works.
In obstetrics, we've frustratingly slowly have accepted the role of a doula in a team with nurses, an obstetrician, a surgeon. We don't have that yet, but the idea of a psychedelic doula, I think, is something that needs to be addressed. And who are people who are outside of medical training that can still provide, like in birth and in death, a doula type of experience?
But you should still try to get some mental health coursework or experience under your belt. It won't hurt, not necessarily towards a degree, but towards understanding it.
Yep. Next question.
I'm really concerned about about mental illness in the family and undiagnosed mental illness within oneself. And whenever psychedelics are discussed, that comes up for me. I'm curious to know anything more about that. Also, what we're talking about with mental illness. So, if you don't have, say, schizophrenia or bipolar in your family, within your aunts and uncles, like how far back are we talking about in your family? And what types of mental illnesses are we talking about that can be triggered by psychedelics?
I mean, as Jishan was saying, one of the absolute exclusion criteria has been history of a psychotic illness, and that generally definitely includes schizophrenia and in some places bipolar disorder. In my lab, we're about to do a study of bipolar 2 depression. So in bipolar 2, people have recurrent depression without full mania. So they generally don't have psychosis as part of their illness, but they have a lot of depression. Those people have all been excluded from previous studies. So we're going to do a very small pilot study to see if we can do this safely and if it's as effective as it is in unipolar depression.
What about something like borderline personality disorder and things like that?
Again, that's usually been a rule out for in most cases, yeah.
Yeah, we're going to be doing a study on borderline personality disorder and MDMA.
We're
is
very
fantastic.
early, right? Like
Yeah.
we're dealing with the safest patients we can. The burdens to doing this research are incredibly high and costly. But with work like this, we are advancing and pushing the envelope in as safe a way as we can.
And we talk about FDA approval as if that's the finish line. That's just one lap. So and one of the things that's going to be really important, and you have to realize that so these phase 3 studies that we're doing with MDMA, because the FDA gave breakthrough status, it drastically reduced the number of patients that had to be in these studies, which is great from a cost perspective. It's not so great from a data perspective, because if you give a drug to 200 people, you might not have a negative outcome that happens less than 1% of the time, but you give it to 2 million people, you're going to see a lot of those cases, right? So when we go into what's called post-marketing approval or phase 4, we really need to be vigilant around this stuff and to be honest about it and to be able to identify people for whom this isn't working so that we don't get ourselves into trouble with this.
Can we do Mike up here in the front?
Make her run all the way across the room.
All the way across the room, making you run. I'm sorry.
I love what you guys are doing specifically around PTSD and the benefits that I see potential for us really understanding. I do want to ask a little bit about the difference between research, traditional clinical research, and the contextualization that you guys have really harped on here. We will approve a drug, effective, non-effective, right? But we're not really thinking about what is the ecosystem you need to be able to deliver it in and how, and that's not so I think of like this context between research and innovation and what that looks like in terms of workflow and environment and all the other pieces that you need to make something like this work. Tell me how you guys are thinking about that as you go through this process.
I mean, Rachel, you spoke to us not having containers for these kind of experiences, and this idea of where do we, this idea of set and setting in psychedelics, the physical setting and the mindset you go into. But there's a third thing called matrix, which is the world you've come from and the world you're going to go back into.
Right.
And right now, the world we're set up for is not really well equipped to deal with that. And so there's been some efforts in, say, psychedelic integration circles and things like that where people can talk about their experiences. But we don't have a lot of infrastructure for people to process these very big experiences. And I think for this to be safe and effective, we're going to need to.
Yeah, I think it's a very important consideration. So there is an artificiality in the research world, and there's no getting around it. There are inclusion-exclusion criteria, which the layman way of saying that is not everyone can be part of the study, so we can't necessarily generalize the findings. And we tend to try to pick safe people. The good news about the clinical world is that once you don't have the constraint of a protocol, clinicians will be able to use these drugs and customize the solutions more. Maybe you need 4 sessions or 5, or maybe, I don't know, but they can customize it more. But this idea of where you're returning the patient to is really very, very important. And this is why we have to do so much research in community settings and places like the VA. We have to know what it looks like in real world settings. Because the research setting is a little bit artificial, so that's how we're stuck. But I think that we will be able to figure that out. We're going fast.
We unfortunately have to leave it there, folks. I want to thank our panelists, Rachel, Jisha, and Andrew. My goodness, this was phenomenal. Thank you for all you do.